Hello and welcome to the first Invest Medical episode. Excited to be here. The Invest podcast has taken a new journey now with Invest Medical. So it's something that's been in the works for a while, something I've wanted to do. And I suppose this is me getting to a comfort level where I'm able to do this. And I guess the goal being is to add something, to invest in yourself, is to understand perhaps yourself. And I guess medicine in general is about understanding yourself. And obviously, a key part of medicine as well would be, investing time into yourself and your knowledge. So I hope that this provides that. Excited to be here. And hello, if you're listening. And I guess a little bit of origins, as this is the first episode. It really came back to my medical education journey and just wanting something like a regular podcast that I could listen to, or something that just gave me sort of key information explained as simply as I could, because I'm not someone who's very academic. So when things are explained, I guess, clearly and concisely, that often helped me and just helped to sort of remember a few key points from different presentations. So basically, the Invest Medical is just, podcast is going to be me talking about a presentation that's fairly common and hopefully useful. Just explaining it as simple as I can, so that I hope that anyone can understand it, whether you're from a medical or non-medical background. But before I do that, I just want to obviously set some disclaimers. I'm nothing that I'm going to give is obviously medical advice. I don't know everything. I'm still learning. And actually, I'm, a big part of my learning journey is doing this podcast. And a lot of the information I am giving and I've read from different resources, textbooks, whatever, is obviously current to this time. So I'm recording this video in July 2023. So, medical knowledge may change, our understanding of things may change. So I just wanted to sort of preface that before I actually sort of started onto our first episode. So the first episode and the first topic I have today is acute coronary syndrome. Now, what is that? Well, that is the actual clinical manifestation of a myocardial infarct, or what's commonly referred to as a heart attack. So I want to firstly, let's say what it is. What is it? So I've got some notes that I've obviously jotted down, and to simply put, it's either the suspicion or confirmed presence of myocardial ischemia. So myocardium being the muscles of the heart, ischemia basically meaning, a lack of oxygen there. So you're not having oxygen to the heart's tissue. Right. So obviously the heart's role, and for those who don't know, heart's role is obviously really important, pumping blood around the body. If we're depriving it of oxygen, then we're not going to be able to produce blood flow to the body, but also the heart itself requires, blood flow from the heart, right? So pumping from the heart, if we occlude the vessels that supply the heart, well, the heart itself isn't going to get supplied to obviously supply the body, but also the heart itself. So within our definition of it, we have, I guess, two schools of thought here, right? So we can have a myocardial infarction with ST elevations, which is what we call an ECG finding, or without, right? So there's two subtypes, and also the non-ST elevation myocardial infarction is also further divided into unstable angina. So that's the absence of detectable myocardial ischemia as per on biomarkers. So we'll talk about what biomarkers are later. But an ECG electrocardiogram is often going to be the key investigation we do, which we'll also discuss, but it helps, I guess, divide the types of myocardial infarction. Okay, so just to recap there, acute coronary syndrome is your ST elevation and your non-ST elevation myocardial infarctions. And then within the non-ST elevations, you've also got unstable angina. And angina, simply put, is where there is an imbalance between the demand of oxygen to what can be supplied. I like to think of that. And there's stable and unstable, and perhaps I can talk about that later. Okay, so the next thing I think that's important is, how does it present? How is the person, like, we've defined what it is, but how is it actually going to show up, right? How are you going to see it? So often what's typically described is chest pain, this dull squeezing type of chest pain that you want to either listen on a history, or if you're listening out for it, you're hearing, okay, well, there's, the alarm bells are ringing when you hear the chest pain. But also associated with it is what we call referred pain. So pain that radiates to the jaw, to the shoulder, to even the top of the stomach area, which is often called the epigastrum, right? Additionally to that, the person might be short of breath, they might be pale, they might be anxious, dizzy, nauseous. These are all terms that they may describe, or you may see some of them, right? You may see someone who's quite sweating or diaphoretic. You may see them pale and change of color, or gasping for air. So that's really important. And the other one is a fast heart rate as well, can be associated with that as well. To continue on, I think it's important also to acknowledge that there is atypical events that occur. So atypical chest pain or atypical myocardial infarctions are common. So these what I've just said, those symptoms or how it would present are often what's common, what we typically see. So it's important to keep that in mind. So we've kind of defined what it is. We kind of know how someone would present, to maybe a hospital, or how they would be feeling, or how they're describing their feeling. But how has this happened? And I think without going into a big map of everything, I think simply thinking of the two types of myocardial infarction is important within our acute coronary syndrome. So there's type 1 and type 2 that's commonly referred to, that I've seen and helped me understand it anyway. So the first one is plaque rupture. So we're thinking of atherosclerosis, or you think of a pipe and a blockage. There's a plaque that's built up and it's occluding. And what happens when you occlude is that you've got obstruction to flow, right? So obstruction to flow, meaning that the heart isn't able to get its blood flow and oxygen, right? And that leads to that ischemic process. So that's type 1. And type 2 is that there's an increased demand of the heart. For some reason, the heart has to pump harder rapidly. There's more demand. And the common causes of that can be cancers. It can be substance abuse. It can be an arrhythmia, perhaps, something that's occurred that's changing how much demand is on the heart. All right. So that's really important of kind of getting us to why it's happened. And I think you could further break this down into, I guess, within type 1, how's a plaque form, what's atherosclerosis, how does eventually it occlude? But I could probably cover atherosclerosis in another episode of its own. But of course, there's a lot of risk factors associated with it. So let's discuss, I guess, the risk factors there. So type 1, I guess your risk factors for that plaque formation is obviously going to be your high cholesterol, genetic factors, ethnicity, also the smoking status, I guess the lifestyle, low physical activity as well. You're considering that there, and then obviously with the type 2 demand, there could be, as I said, cancer as well. That arrhythmia, substance abuse, those are the risk factors that may have caused or the underlying process. So we're just considering that. Okay, and then the next one, simply put, well, we kind of know, I guess, what it is. We know how it's sort of presenting. We know what's happened in terms of underlying it. So how do we actually investigate it? And I mentioned that the first thing you want to do is the electrocardiogram, and there's what can be handy also before you even get to that, or you should be doing an ECG anyway, is doing something called a heart score. It's a validated score that you can use, and it's a calculation that can sort of stratify how worried you are. But regardless, when we're going through this, an ECG is necessary. So 12-lead ECG. If you haven't looked at ECGs before, we can discuss that as I'm sort of kicking this down the road as well later on. But looking at, how's the electrical conduction of the heart and electrical changes of the heart resulted from this ischemia, right? So that's what we're trying to look for, and those ST elevations and non-ST elevations are going to be what you're looking for, but also looking for any new onset bundle branch blocks, any arrhythmias, anything as well, right? That's going to be important, and there's different criteria as well for that. But just broadly, how do we investigate it? We want to do an ECG at the bedside, and then on your blood and your biomarkers, as we said, we want to be looking at troponins. Now, troponin as a biomarker is something that people investigate at different time points. Now, I would say that is up to your local guidelines as to what you do. I've seen, in 2 and 4 hour intervals done between those two in emergency, but perhaps, it could be different wherever you are. So look at where those are taken in your local guidelines at what time points. But troponins are taken as well as other biomarkers. I know that there's obviously CKMB. There's quite a few biomarkers, and they peak at different times. It's important to appreciate, but broadly, when you're thinking through this logically, what do I need? Well, I need some sort of biomarker, and we're going to do that on a blood test, and troponins is going to be important. Now, obviously on your blood tests, if you're taking blood, you would do perhaps a metabolic screen looking for other underlying cause as well, can be important, but really specific, obviously is going to be your troponins in the acute setting. The next thing that I think is more than that special tests, like, you've done your basic bedside ECG, you've done some bloods, is your special is looking at a transthoracic echocardiogram. The echo is going to, I guess, determine if there's any structural abnormalities in the heart, determine if there's any valve issues, anything there. So that as well is an investigation you'd perhaps do later, but something to consider and also suggest. All right, so I guess now that we're following our path of, I'm going to keep going over this, I guess the structure of, we know what it is, we know how it presents, we kind of know what's going to happen and what's caused it, we know how to investigate it, right? So how do we manage it? Of course, with any management of any condition, it's going to be up to your local guidelines there, but also it's going to be important to check the most up-to-date information, so using resources there. But I'm just going to give some broad, I guess, principles there. So I think you've got someone in front of you trying to help them. I've seen the acronym MOAN, or MOAN. People use different ones. So MOAN is one that I've seen, where you're giving morphine, oxygen, aspirin, and nitrates, sublingual nitrates, right? I think that's a really nice mnemonic, just to think, I've got someone in front of them, I need to make them more comfortable. I need to help with the pain, help with aspirin, which is an antiplatelet, and sublingual nitrate as well, and then the oxygen if required, of course, but oxygen often is required, and looking at the saturations as well. I've seen 94%. That's when you want to start oxygen, but I think it's important to check with your local guidelines as to what they do. You're going to hear me use that line a lot with the local guidelines, but it is important to see, because everything's different and everything. There's often clinical reasoning behind that. Okay, so ultimately, so that's obviously the patient in front of you, but we do have importance of time, and time does come into the management. And as we've been saying, with different guidelines and local understanding of what the management should be, there is different time windows that you can access percutaneous coronary intervention, which is obviously going to be the main intervention we want to get to which basically is where you stent or balloon the coronary artery, so that we can have blood flow through there and oxygen of the tissue. And that requires some time, again, going through what I've seen in my local guidelines, anticoagulation beforehand. So considering, what is the time window, which I recommend you look up before we, so we can do percutaneous coronary intervention, or PCI. If you're outside of the time window, you can also consider something called thrombolysis. And there's sort of antiplatelet loading as well with that. So again, that there will be, a flow chart or a sort of a local pathway guideline chart that you can go through with timelines and things like that. But I guess commonly what we think of is, when we want to manage this, hey, we think broadly, we've got the person in front of us, MOAN kind of helps with that broadly. Then we can think, okay, based on time, where are we at? All right, do we have a window for percutaneous coronary intervention or PCI? If not, can we go to thrombolysis? What else can be done? And of course, with management, you want to call in the experts being the cardiologists or the cardiology team. So obviously that's going to be part of the mainstay there, and getting, depending where you are, you want to get the patient to hospital, to ED, and then obviously down the chain it goes to contacting the cardiologist. But yeah, I guess that is the summary that I thought of acute coronary syndrome. So just reviewing it from the top, what is it? Acute coronary syndrome is sort of our clinical manifestation of a myocardial infarction, but also within the ACS sort of title, we have unstable angina, which is within the non-ST elevation acute coronary syndromes, and then we have ST elevation myocardial infarctions, or ST elevation ACS. So that is what it is. How does it present? So I talked about the typical, the chest pain, the radiation, the shortness of breath, anxiousness, all of that, which we're going to be seeing. And then when thinking, how has this happened, or sort of how is it broadly, what's kind of causing this, or what's underlying? I think of the two types, type 1 and type 2 myocardial infarctions, which is either, is there a plaque blocking, or is there more demand on the heart? So I think that's an easy way that I thought of thinking of it. And then within that, you can obviously think of the risk factors and specific underlying causes. Then how do we investigate? Thinking, bedside bloods and special investigations. Special investigations being imaging. You're thinking bedside, you want that ECG really quickly. We want to compare to previous ECGs, which I didn't mention, but you should compare to a previous ECG if you can. just to see are the changes normal for this patient, what's sort of going on, bigger picture. Bloods, you want those cardiac biomarkers, which are troponins, and then your special, if you want to, looking at that TTE and looking at the actual structural aspect of the heart. And then we talked about management. So of course, in the personal hospital, you're an emergency, wherever you are, it's going to be important to look at your local guidelines, and then contacting your cardiology team. But just some principles to consider for perhaps the purposes of exams or OSCEs or whatever it may be is thinking morphine, oxygen, aspirin, and sublingual nitrates. What time window are we in? As I said, that'll be guided by your local guidelines. What's the time window? Can we get to the cath lab and do PCI? What can we do thrombolysis? And ensuring what's possible as per your flow chart or your local pathway. So yeah, I hope that was useful. Obviously my first episode, so it's going to be a challenge. I've got to make it smoother, I suppose, but I'm just starting out, so bear with me. I hope that you got something valuable out of this, and that in the subsequent episodes, I can really get some feedback from everyone to see what I can improve on and what I can add. So thanks for listening. Hope it was helpful. And I'll be back with another episode soon. Thank you.